The title of this presentation is Combination Therapy with Stretching on Triceps Soil plus Electrical Stimulation to Tibialis Anterior Decreases Plantar Pressure during gait by modulating the abnormal gait pattern in diabetic patients. Introduction. Diabetic mellitus underlies up to 8 of 10 non-traumatic amputations, of which 85% follow a diabetic foot ulcer. And diabetic foot ulcer comes from multiple factors. High plantar pressure is often observed in patients with diabetic peripheral neuropathy and strongly related to the development of plantar forefoot ulceration. About causes of high plantar pressure on forefoot, decreased ROM in ankle dorsiflexion and characteristic change in muscle activity has been reported. Decreased ROM in ankle dorsiflexion causes early heel off and decrease in shock absorption. As characteristic change in muscle activity, increase of plantar flexor moment during first half of the sun's phase has been reported. Therefore, improvement of both factors could suppress forefoot plantar pressure during gait. Stretching is a traditional and effective therapy for improving the limited joint mobility. We reported weight-bearing stretching increased the ankle dorsiflexion (ROM) in the patients with diabetes mellitus. Electrical stimulation is a physical therapy using electrical current for muscle contraction and relaxation. Reciprocal inhibition is an important action of this ES. Reciprocal inhibition is a neural pathway between agonist muscle and antagonist muscle, and muscle tone is ameliorated with an application of ES to the antagonistic muscle. About the combination of these therapies, ES enhances the effect of stretching in ROM increase, and the therapeutic mechanism of ES and stretching are totally different. Therefore, synergistic effect by independent physiological actions from ES and stretching could enhance the suppressive effect on plantar pressure. The purpose of this study is to investigate the influence of the stretching, ES, and combined therapy on the ROM and plantar pressure distribution during gait in patients with diabetes mellitus. Methods: 30 patients with type 2 diabetes mellitus was enrolled. Study design was randomized crossover design. We evaluated the immediate effect after intervention with washout period of 2 days. We have 4 intervention groups of control and electrical stimulation, stretching, and combination therapy of ES plus stretching. Patient characteristics were as following. Intervention procedure of each therapy is following. Measured items were following. We evaluated plantar pressure, ankle motion, and gait parameters. Results. Pressure time integral of plantar pressure was significantly decreased on medial forefoot by combination therapy. Peak of plantar pressure was tendenciously decreased on medial forefoot by combination therapy. Contact time during gait was decreased on medial forefoot by combination therapy. About the COP excursions, we evaluated front-back excursion and a medial lateral excursion. As a result, increased medial lateral excursion by combination therapy was observed. Next, we divided medial lateral excursion into medial excursion and lateral excursion. As a result, increased lateral excursion by combination therapy was observed. About the ankle motion, increased ankle dorsiflexion angle by combination therapy was observed in passive ROM and ankle dorsiflexion angle during gait. About the gait parameters, no parameters were changed by interventions. About the correlation, negative correlation between difference of lateral COP excursions and difference of PTI under the medial forefoot was observed. Discussion. The first point is decrease in pitch pressure time integral on medial forefoot by combination therapy. In the present study, decreases in pressure time integral on medial forefoot correlated with increase in lateral excursion by combination therapy, and contact time on medial forefoot decreased after combination therapy. It has been reported that decreased lateral excursion caused the early contact on medial forefoot in patients with diabetes mellitus. Therefore, increased lateral excursion by combination therapy shortened the contact time on medial forefoot, resulting in decreased pressure time integral on medial forefoot. Second point is increase in lateral excursion by combination therapy. In the present study, ankle dorsiflexion angle during gait was increased by combination therapy. It was reported that tibiotalar joint axis is oblique slightly toward lateral. Tibia inclines towards lateral direction with increase of ankle dorsiflexion during stance phase. Therefore, increased ankle dorsiflexion angle during gait by combination therapy caused the increase in anterolateral incline of tibia, leading to the increase in lateral excursion of COP. The final point of discussion is increase in ankle dorsiflexion in stance phase by combination therapy. This has been reported that stretch reflex of triceps sore in stance phase increases plantar flexion torque, and electrical stimulation to tibialis anterior suppressed the stretch reflex via H reflex inhibition. Therefore, it is considered that increased flexibility by stretching and inhibition of stretch reflex by electrical stimulation increased ankle dorsiflexion angle in stance phase during gait. Conclusion: combination therapy by electrical stimulation to tibialis anterior and weight-bearing stretching to triceps sole increased the ankle dorsiflexion angle in stance phase and the lateral excursion of COP, resulting in the decreased plantar pressure on medial forefoot in patients with diabetes mellitus. Thank you for listening.